dental council, and they told you either removes the implant or they get his license. So the beginning was not a very good one. Then some other doctors, they decided to start modifying this structure, make it a little bit bigger and lighter, have better, remove better, but still something was not working with these implants. And this unfortunately is what is left in the mentality of many doctors, and why somebody thinks still that they don't work. Then years were going by, Lincoln did everything in implantology, we know it very well, it's a very good implantologist. They were using the titanium meshwork to produce these implants. They were starting to see that there's a problem in the production of these implants and afterwards in the outcome. So the years go on and the second generation saperiosate implant came out, but the success rate is very poor. I told you I need to be predictable with my patients, so of course I cannot have 100% of success. Otherwise I wouldn't be a doctor, I would be a magician. But 36%, this means that you operate 10 patients, at least 6 of them, they will have problems. This is not acceptable. And when we look at the years that we are looking around the 70s, this is the moment where the osseointegration was defined. So this was the moment where there was a change. So they said, why should we have so much problems when we can start placing the implant inside the bone? And that's the moment when really the subperiosteal implant were left and the osseo implant, they came along. But why they were not working these implants? We have to ask ourselves why now? And the problem was the poor choice of the site where they were placing. They didn't know how to plan this type of implants as we do nowadays. They were producing these implants by taking an impression of the bone. So they were doing the first procedure, opening a flap, taking an impression, and closing the wound, going to the lab. With the lost wax technique, they were producing the implant, and then going back after 1 week to do the procedure. You can imagine how, nowadays it's funny. We are talking about digital, we are printing. I send the crowns to the lab here in Vietnam, and they send them back after 1 week. After 3 days, I don't have a problem. So they were poor judgments of the restorative procedures. They were not looking backwards from the prosthetic, the final prosthetic. They were just placing something and hoping just to help the patient. So there was no fitting of the implants because made on the impression of the bone. You can imagine. They were not talking about occlusions. They were not talking about osteosynthesis screws. So this was a recipe for disaster, but the idea was good. Still, some people kept on trying this field. Then we find one of the biggest names, I think, in implantology, Scarmish, that he understood that somehow we needed to improve the integration with the bone. So they started on the metal bar, they started putting hydroxyapatite, and they have seen that the results, they were improving very much. As we will see, we got almost to the level of the implantology that we have nowadays with even 30 and 20 years follow-up. So we start seeing that by changing a little bit the idea that we have the implantology, changing about the material, we can have a better success. But still was not the time that we're living in right now. Now we have the 4th generation of subperiosteal implants. It's the one that we are living now, that we are in the digital dentistry. It has already been published. These researchers that I work with, and this was the first study in which the subperiosteal implants that were used after being produced with laser melting. So we can imagine in the past we were doing the lost wax technique, so using the waxing the cast, waxing the structure, then the lab was making this with chromium cobalt. And now we're talking about titanium first, and second, we're talking about laser melting. And we will see in a second why using the laser melting is a game changer. And the results are very good. These implants are performing very well after many years without complications. We are using sterile implants, something that was impossible before. Those implants in the past that were made in that dirty technician lab, and they were just placed to the patient. Maybe with hydrogen peroxide they were clean. Maybe. We can imagine nowadays that we work in the operating room. And I can show you also, this is one of the articles that we have published lately, where we do the rehabilitation of the upper arch, and we see that the patient, they have very good success with this type of rehabilitation. So we have some more that I hope I will show you in the future of articles. So what is the new generation really? What has really changed? So at this point we are prosthetically guided, and we do this not just for these implants, we are doing this for the standard endoosseous implants. You do, many of you, I'm sure they are using guided surgery. I was talking, I had the pleasure to spend a few days here in Ho Chi Minh, and I've met a lot of doctors, and I've seen how much they are working into this direction. They are interested in the guided surgery to give a better result for their patients, and we are doing the prosthetically guided treatment for our patients. We have different type of abutments, and we were using both monophasic and multi-unit, even though nowadays we are only using multi-unit abutments because they're easier. We are screw retained. It's easier to remove these bridges, easier to work on them, gives us the possibility to make more changes. We are using titanium alloy, so we are not using chromium cobalt. And we know from the literature what was the problem with chromium cobalt. We know the Tramonte, Italian guy from my city. He was one of the first doing the screws, the Tramonte screws, and they were made of chromium cobalt at the beginning. And he was showing that chromium cobalt was undergoing the integration. However, it was losing very early also the integration. And now we are using titanium. And of course, they are made with laser melting. So the production and the real planification is the game changer here, right now. So let's take a look what was in the past and what is right now. In the past we had an impression of the bone, so with no accuracy. We had the loss wax technique for the production of the implants, and there was no prosthetic plan. So now we have a CAD-CAM. We know CAD-CAM, we can do whatever we want. We have no problems anymore. The machines that we have, they're very precise. They're made of a titanium alloy, the same titanium alloy that we're using every day for the dental implants. And we as implantologists, we know it works very well. We do it on a daily basis. It's a full customization, but overall, I think we can sum with these implants, they are becoming predictable. And before we start looking at the patients, why do they work well nowadays? Why we say that now there is the correct understanding of the physiology? Because when we're looking at the skulls, and I'm sure that most of you that had the training in surgery, they know very well that we have to look at the skull, we have to look at the type of bones that we have, and we will find that we have three vertical type of buttresses of bone. What is a buttress of bone? It's a dense column of bone made of bone type D1 that doesn't undergo any resorption. And one is the canine buttress that is going from the canine up to the glabella. Then we have the zygomatic buttress that is going from the tooth number 6 and from the first molar up to the zygoma. And then we have a distal one, which is a pterygoid buttress. So physiologically, these three components of the skull, they are made to distribute the forces to the neurocranium. So we should exploit physiology. We don't change it. We cannot change the resorption. We can exploit what we have from the nature. And nature is the most perfect thing that, of course, we have. And what about the workflow? Now the workflow is not analogic anymore, it's fully digital. How does it look like, this workflow? What I do, I start from an impression. And even if it's an dentalus patient, I scan the patient intraoral. And I make the perfect denture for this patient because I know that I need to have a perfect fitting of the denture. I need to have the correct vertical dimension. Basically, I'm planning my final restoration with the denture. And I also scan the denture inside and outside. I make a copy of this denture. And this is the denture that I'm going to use to do a CBCT. And at this point, I can go ahead with the planning. And for many cases, especially when we have metals in the mouth, when we have a big face of the patient, so a big skull of the patient, we are using a device, it's called EvoBite. It's basically a device that we use during the CBCT that afterwards can be scanned, also this component, and then matched together with the X-ray. So what we do, we really scan the antagonist, we scan the denture, that it will be the final work. We are placing the evobite blocked between the upper and lower, so we reline it with the silicone. We scan the evobite, we have the dentulous arch, and we have the impression, the CBCT with the evobite, the mount. And that's what comes out. That's what we see. And that's the moment that we realize how much we are missing between vertical dimension and horizontal dimension. These are the real thing that we're going to see. Okay? So when I look at this, I realize that can I perform a sinus lift here? Can I go even higher? How long will be my teeth? How long will be my prosthesis? Impossible. I need to do something different. So once we have all the files, all the digital files, we have the STL files, we have the DICOM file, at this point we can merge them together on the software. And how are these implants produced? These implants, they are not made by just a technician, they're made by a special machine, the laser melting machine. What is the advantage of this machine? This machine is working layer by layer, going up, 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 and producing a structure. What is the big advantage? Is that there is no voids inside the surface of our implants. So our implants, they are made of full thickness of titanium. So they present no defect inside. So no defect means no weaknesses. So they will be very strong in time. And what it seems obvious nowadays, because we're even producing the structure, if you're using with a porcelain fused to metal, you're using the laser melting. If you're making a mesobar, you're using laser melting. It was not this way in the past. And why is that important? Because this is a case, it was made many years ago, and there was a problem in court, so they sent us to make a study to understand what happened. Because we as a group of producing the not producing, but utilizing the system and publishing in this field, they sent us to review. And what we found at the microscope was that there are a lot of voids inside. These were the old type of subperiosteal implants. And why was this happening? Because they didn't use as laser melting. They were using the lost wax technique, and during the cooling of the metal, they was producing the voids inside. Now, these voids are not present anymore. That's why the production really changed this field very much. And we can trust these implants very much. Salute. Then, afterwards, when we have all the files, we can plan our implant for the patient. And you see, this is the laser that is working. It's working overnight, and this will produce our implant. And when we come the day afterwards, we find this in our office. And this is how it really looks like. The rest of the powder, and that's from what they will have to work afterwards. What happened afterwards? Of course, we have to do a thread inside the grid, inside the implant for the screwing of the abutments. There is a surface modification that we do for these surfaces, but once it's produced, we can move on to the surgery, and that's the part that we like the most, of course. Opening of the flap is a generous flap. We make the osteotomies, because what is important that all these abutments that are inside the osteotomies in the bone. How do we perform these osteotomies? I will show you afterwards. We kind of use a surgical guide, but we cannot trust a surgical guide in this field. Unfortunately, here the surgeon makes the difference, because we have a calibrated burr that we are using, and we replicate these cuts that we make in the bone on the real patient. Then I use a template. This is an implant that is a template. And only once I have the perfect fitting, you see that in this one, I don't have any thread in the multi-unit. They are fake ones. This is just for a try-in. And afterwards, I take out my subperiosteal implant, and I touch it only once. It stays as sterile as possible for as long as possible. And then, few screw laters, I have my implant in place. That's how the process more or less looks alike. So what are really the advantages of the subperiosteal implants overall? is that we have this correct distribution of the forces, as we have seen. So, working physiologically. We have a graftless procedure, so we don't have to choose what type of technique, what type of material, wait for the healing. The patients, they have to wait for a long time to wear any temporary solution. And we were talking before with our translator, that I thank very much for the translation, and she will say, I cannot tell my patient to stay 3 months without a tooth. Can you imagine after a big graft how long they have to stay without a denture? Is it possible? We have a prosthetically guided treatment, so we know that afterwards the prosthetic part will be fun, will be easy, will be fast. We are working with a CAD/CAM, so we can produce any type of structure. There's no difficulties, there's no problem with the impressions. We are printing out the models. We are doing what we want with the computers. We are avoiding cantilevers. I'm not a big fan of cantilevers. I try to avoid them as much as possible. We are using a titanium alloy, and it's the same material, it's a gold standard. That's why we're using the implantology. And last but not least, we have a big surface contact of the implant. It's really hugging the maxilla. We are talking very often about the bone-to-implant contact, and we are even trying new strategies, the UV treatment of the surface to increase the bone-to-implant contact, to increase the post-integration. But here we have a huge success with that. And what happens while using titanium is that we find that between 3 to 8 months, this titanium has interaction with bone. We are using osteosynthesis screws made dedicated for this type of treatments, which are made of titanium, so they integrate like an implant, but also the implant itself interacts with bone. So this is something that really gives us some success. With my group of research, we decided there was not enough to look at bone. We need to make a difference in the research, because now we have an implant that is touching as much bone as soft tissue. And we did the first analysis. Is the first article ever published in which 5 different types of laser melting materials they were studied. And we did the gene expression analysis of the genes responsible for the integration of the fibroblast with titanium. Why is that important? To create a great seal around the abutment. And this, we know that the seal is something that gives us the success over time. I cannot show you at the moment the results about the osteoblast because it's in publication right now, but we also made the same study with the gene expression, with the genes responsible for the integration for the new surface, and the results are very, very interesting, maybe next year. So, this was our big introduction on how we used them in the past, what was present, and now we have to see what are the real clinical cases. And we have seen a big implant. We are used to see these very big implants when we're talking about the subperiosteum. However, I decided that subperiosteal implants, they can be used for many different techniques. And also this is something that we have in publication right now. I decided that I wanted to work for the small atrophies. So I want to introduce you this patient. This is a patient that she came to my office because she wanted to restore some teeth. Okay. We take a closer look and we see that the lateral incisors, they look kind of funny. The first time I see the patient, I say, okay, she has some temporaries placing them out. We take a closer look, and yes, these are real temporaries because they are blocked from the palatal side. We see that we have some Maryland type of bridges. Okay. Take the X-ray. I look at the X-ray and I don't understand this patient because she has 2 implants in the mandible with no crowns. She's taking care of the upper incisors, and in that moment I asked her if I placed this implant because I'm not sure I did because I don't recognize this implant. She said, no. Yeah, they were placed in a different office. I come very far away from here, but the dentist who did the lower one, they needed to restore, also placed 2 implants in the upper arch with a bone graft. I lost 1 implant after 1 month. The second one, when it was uncovering the implant, it was movable. He decided to do the crown, and after 1 day it came off, and we have a problem now, we have in court. Okay, what can we do for you? I take the CBCT, and I see that they have a lack of bone for the lateral incisor. And here, once again, I can ask you, what is the treatment plan? Well, I could tell you, many could answer that it's the same thing that did the dentist before. Bone augmentation, implant placement, wait for 6 months, 4 months, you name it, you say it, and then we do the crowns. This patient is desperate. She has been waiting for 6, 7 months to have the crowns. She lost one implant, the second one she lost after 1 day. She doesn't want to wait any longer. She said, no doctor, I need something immediate. And when I will pack myself into the same procedure that I'm sure the other doctor was an implantologist as well, so he must be trained. He was not successful. Do I think I'm much better than him? Maybe I'm just more lucky. So I decided, okay, see you next week, and we will see. We start with the digital wax up, and we see that where the crowns are supposed to be. And in that moment, I say, why we don't go back to the physiology? Why don't we use the canine buttress? Why don't we use the palatal bone that are made for distributing the forces we are using every day? And I propose, what do you think about placing an implant that is customly made for you and it goes around the bone? She said, I like it. I like it. But you have to take the pictures afterwards, you have to show me. She works in the operating room every day and she likes to see the surgeries. So when she saw that, she agreed for the treatment. So that was time to go to the operating room and do the procedure. So when we start opening the flap, it's nothing more than the flap that we will do for bone augmentation. We open our normal flap, we expose them up to the spina nasalis. We don't need to open too much. Yes, also the palatal, there's no need to remove the incisor papilla in this case. So I just suture together the palatal aspect to have more easy access to the bone. And then I can start my osteotomy where I will put my implant. It was already after the osteotomy, of course. I'm not really satisfied with the fitting of the implant. I try with the temporary crowns. Move it. In this case, I didn't use a template. This was a different time. We didn't have this idea yet. Of course, these are new things, so we are changing them. We are making some changes over time. Once I find the good fitting of the implant, and I use the temporary crowns to make, this is like a checkup, control, to know that I'm in the good prosthetic position, I can start putting down the osteosynthesis screws. So, it's an easy procedure. We know how to do this procedure. We are already doing this for other type of surgeries. Important thing is to go and engage also the spina nasalis because it's a very strong bone, and we know it's a good success. But when we are using these screws they have a diameter of 2 or 2.3 millimeters and a length from 4 to 10 millimeters. When I'm using a screw, like in this case, there's a diameter of 2.3 with a length of 8 millimeters, is almost a dental implant. We have dental implants when they are 3 millimeters. So we have 2.3 and 8 millimeters plus more screws. So you can see that we have a very good stabilization. We are talking about just lateral incisors here, and so we don't have big forces. Of course, you could say that one of the treatment for the patient was the bridge, but the patient didn't want to have a bridge. So we put, as you will see, this is a very big screw that's going in. There was a question? And then we can go towards the palatal side. Yes, to make our osteotomy and put our osteosynthesis screw. As you see, the screw goes in. Then we can move to the second side of the mouth. Just making sure that the screws are tight. Yes. In each implant, more holes are made for the screws in case that the surgeon doesn't find a good stability of one screw. He can decide not to place it. Then we go to the second side. As you see, we do the osteotomy. I measure on the model, the stereolithographic model that I had next to me. I see the amount of reduction that I need to do. Then I check with the implant the fitting. So this is a moment where you need to work a little bit, stay calm and find the perfect osteotomy to place the implant. You cannot cut too little, you cannot cut too much, and you cannot leave any sharp edges. So once we have the good fitting, we can start placing the screws. Check the temporary. We remove the sharp edges, because the sharp edges, we cannot have any sharp edge on the bone. Once we remove the sharp edges, we can start placing back the screws. We know the process of putting the screws. It's a simple procedure. The difficult part was just the fitting of the implant. And also we develop a protocol in which we not only place the implant, we also put something to create a better profile, because especially if there was a genesis, as we'll see later on, of the lateral incisor, usually we have a lack of bone that we need to deal with. So afterwards, after putting the implant, you see we have perfectly on the bone, we are adapted to the bone perfectly, so we don't need to do much more. We put the PRF, these are 4 PRF sutured together membranes, and then on the opposite side also will be 4 PRF membranes sutured together with resorbable suture and suture under the soft tissue to create an augmentation of the soft tissue. I like to use this material very much. I think we have seen that the gene studies and the genes are responsible are also for these implants. The fact that I can put growth factors on top, I think is a fantastic idea. And then of course, a suture that we all know how to suture. So let's look at the case once again with the pictures. We'll see we have the exposed bone with the osteotomies. You can see the adaptation where the grid is going to be on top, and the implant in place, anchorage on the palate, on the buccal aspect, very good anchorage. And the patient goes home finally with the fixed teeth on the implants. So this was the request that she had from us. So we were able to address the request of our patient, and that's our job. We see the temporary still in place, and the control on the X-ray, we see that we have good position as planned. Then it was a difficult talk at the beginning because she was looking only on the lateral incisor. But when we are looking at this patient, we are seeing that we don't like this, especially on the big screen. It looks even worse. She couldn't see. That's why we also project for our patient on big screens their mouth. You see that the central incisor, they don't look the best. So we did analysis of their spine, and she didn't want to do a big procedure like the veneers. So we decided to do some composite build-ups and some temporaries, new temporary on the lateral incisors. And then the final restorations, we see that the crowns that are made of lithium disilicate, It looked very nice, in harmony with the central incisor. So the patient changed from this to that. Of course, we built up also not only the central incisor, but also the canines. But we see how the aspect is changing very much by just working in the front sector. And we did this in a very short amount of time with predictability. That's what she wanted from us. She didn't care what we were going to do. She didn't want implants. She just wanted nice teeth. And I think we managed to do that. Now we can take the bar a little bit higher and see what happens when we have another young patient with the genesis of the lateral incisors, however with a high smile line. This is the cases that we don't want to treat usually because we know they are very challenging from an aesthetic point of view. And when we have a genesis of the lateral incisors, we have to address any problem. Just not only the fact that we have a genesis, but most likely we are going to have this defect inside the bone. And this is a nightmare. Because even if I place an implant, I cannot leave an emergent profiles that look like that. The foot will get stuck. Inflammation will be there. It will not be aesthetic, especially for a patient that is showing the soft tissue distension. So we take our X-ray, and when I took the CBCT, these are the two crests that I have present. And I started thinking, what should I do? Should I do a bone graft? Should I place the implant? Should I do an expansion? Well, coming from the good experience that I had in the past, I said, what about in one procedure? I will do the implant placement, the bone graft, and then I put the temporary crowns on the bone graft. So once again, we go back, study the case, but this time I cannot anchorage my implant on the buccal aspect, because if I will see something under the soft tissue, this patient, she will kill me. She's a young patient. So in this case, as we see on the left side of the screen, on the buccal aspect, there's almost no method, there's only a small lip, and on the palatal side, I got all the full anchorage of my implant. So let's go once again to the OR. Let's go to look at the procedure, how it looks like. We open basically the same flap as before, even though at this time on the buccal aspect we don't need to elevate that much. What we will need to do is to improve and elevate more on the buccal, on the palatal aspect. So I suture back the palatal side. I don't need to be very aggressive in this case with my cutting the incisor papilla. I just need to have enough space to get in the middle of the palate to put my implant. And then here I start with the osteotomy, on which I will put my implant. Continue the second osteotomy, and then I will do removing the sharp edges, both sides, and try the implants, the fitting of the implants. And on the palatal side, I also need to do some modification. I will show you once again, because it's because on the palate is never smooth as we think. It's actually very hedgy. It's rough. So we need to make it smooth, especially the area where our implant is going. And we know how to do this procedure. We do osteoplasty every day, so we know how to do it. We just need to do it in the right position. Then we try in the implant. A little bit of press fit. We press fit with a hammer inside to have the perfect mechanical block, because what we have with these implants is the block from the screws, but also a mechanical block between the fixture and the bone itself. Try with the temporary, go to the second side. I'm not satisfied yet with this one, I will remove it afterwards. Finish you see the rounding bone and placing my implant. With a press fit, and it goes down completely inside the bone. Move the first one, so I could see from a prosthetic point of view that I was not correct. So I run a little bit more the osteotomy, make an imitation for the implant. And put it back. Now we have the correct position. Placing the screws, of course, our 3 screws on each side, as we have seen before. And then in this case, we have seen the big defect that we had on the buccal aspect. So besides putting our screws, I also put a graft on the buccal aspect. I don't care about this graft. It's not important that we produce the bone for the placement of my implant. I don't care if the quality of the graft is not full bone, but it's mixed together with the graft. My idea of putting the graft here is just to do an augmentation of the tissue to have a good aesthetic at the end. So we put the graft on top. The PRF membrane and suture, and that's it. This is the end of the procedure. It's a procedure that is quite fast. So we see the pictures, and once again we see the osteotomy, we see the perfect fitting of the implant, the correct abutment position from a prosthetic point of view. You see, here we can immediately place the crown. From the palatal aspect, we see we have a good fitting of the implant. We have the graft, and look at the architecture already of the soft tissue. It's changing at the moment. So we do a X-ray. You can see the fitting. It's confirmed that it's perfect. We see our graft, and the patient goes home with the temporary graft. So after the temporary graft, we come in. We did the final prosthesis, and what we see from we had before, and how she looks now. It's a good smile. We just did the lateral incisor of her, but you see, we don't see any defect at the level of the gamma. She has a gamma smile, so it means that we work correctly. This technique, I used it also for the lower arch. I will show you very briefly. Patient with look at the mergers of the inferior alveolar nerve. I put in place a standard implant, so this is the try-in, this is the final implant in place, have a good fitting, and she goes on with the bone, as you see. Otherwise, here wouldn't be a nightmare. What was she supposed to do? Placing another place the inferior alveolar nerve is a big procedure. This I do in 30 minutes. And have the correct placement of the abutment. I will show you this case because this case it's what really changed my mindset about the subperiosteal implant. And that's because this patient came to us like this. There are many things that are wrong here. Yes, the period, the endo, many things are wrong. The patient, the first step, he wants to treat only the upper arch. We decided that the lateral incisor is lost. At the moment, the lower, we are not looking at it. The periodontist is keeping it until we will work in the lower arch. And so what I propose to this patient is the first quadrant, once again, the first quadrant, the rehabilitation with the implants, informing that the extraction in the past, but they were 5 months, and still I could see no good healing of the hard tissue. Anyway, I said, don't worry, I trust my bone grafts, so I will extract the lateral incisor, place 2 implants, place a pterygoid implant in the posterior, we do a bone regeneration, we will be fine. Okay, and that's the procedure. So I open the flap, look how it looks, this bone. And this is 5 months after extraction. I don't trust this bone much, but still, I place my 2 implants. I can show you this was, we'll go very quickly. The opening of the flap, how tricky it was when we got to the those defect. And you can see really the anatomy here, that is the scalloping of the tissue. You can see better from here. Then I place the pterygoid implant in the posterior maxilla to get a distal anchorage. 2 burrs, pilot tree, second burr, and the third one is the implant. Here's the implant going in. So first procedure started. Pterygoid implant, extraction of the lateral, 2 implants, and a bone graft. You see the implants, they were missing a lot of hard tissue, so I put the graft, I put the PRF, and still do the checkup. I have my pterygoid, I have 2 implants in place, and still no teeth in the mouth of the patient. I wait for some time for healing, 4 to 5 months, and I go back in. I do 1 more graft, put membranes on top, place 2 implants, and wait. And I told him, finally, now we can do the second side. I said, no, second side, I cannot stand it. It's 1 year that I'm in treatment at your clinic and I have no teeth in the mouth. I only spend a lot of money for screws and bone. I don't care, I want teeth. So, okay, let me think about it. Maybe we'll find a way, a solution for you to have fixed teeth and in one procedure. So what I did, I placed a subperiosteal implant on this side, just in the second quadrant, with the monophasic abutment. I found a good anchorage on the zygomatic and the canine buttress, on the palatal bone, and on the same day of the surgery, he went back home with the bridge in this area. And that's when he asked me, why you didn't do this before? Because I trusted too much that bone and still my graft. So the patient, of course, it was such a fast procedure. I also placed the implants in the lower arch for the with an immediate bridge. And this is what I call a split mouth, because we see one side and the other side. And here on the right side, still at the temporary bridge, on the second side, he immediately got the temporary bridge. So we see the mindset is changing, because our patients, they want the teeth immediately. They don't want the teeth in 6 months, 8 months, maybe. We need to address to be predictable. For me, it's the only way to be predictable. Let's now start slowly getting to the more complex cases. This is a patient that she was referred by my colleague, and on the first visit, the patient told me, you know what, I went to a clinic because I had the problem with the upper denture. I couldn't have the upper denture in the mouth, but I came back home and had 6 implants in the mandible. So, okay. And the doctor told me, yes, I couldn't do anything in the upper arch, so I did the lower. Now you take care of the upper. What do I see? I see that I have a big curvatization of the sinuses. I'm very happy because I can see that I have a tuber maxilla. However, here I have an impacted tooth. Okay, let's take a CBCT. Maybe I can do overdenture or something. And I see that the only thing that I hear, I have a knife edge that is impossible for me to graft it. And in the posterior, I really have no bone, virtually no bone. So what to do for this patient? First of all, I start with the planning of the case, the correct planning. So I talk to the patient. What do you expect from my treatment? What will be your expectation? I want a short treatment of time, because I am older already. I cannot spend so much time at the dentist. I want to enjoy life. I want it to be predictable, that I know I will spend money, but I will have my teeth, and I want a fixed restoration, because she's avoiding going out, meeting with friends, going to the restaurant, because the denture is moving all the time. Okay. So I sum it up what she wanted. Overall, she just wanted to improve her quality of life. So what are the options that we have for this patient? Removable denture, but she wants a fixed solution. Bone augmentation and delayed implant placement, short treatment time, it's not possible. Zygomatic implants, maybe, but I don't know if I will have the correct position of the abutment. Subperiosteal implant, I like this option. So I take the pictures of the patients just to do the planning. I take the videos of the patient and I talk to her. And look here, she has the glue between the lips. This means that this is a patient that is living a nightmare with the denture. And I'm asking her what are the expectations. And of course, we do our planning of our teeth. We do the radiological template, which is our final work. We have the correct VOD, fitting, shape of the teeth. Then from this we do CBCT, we superimpose everything. We are creating our implant that is created on the custom made for this patient. And then finally we produce the implant. So with a full digital protocol, we are able. We didn't take a single normal impression, we are working all on the computer and we are superimposing the project, as you see. So I know prosthetically where my abutments need to be to the production of my implant. This will be what I've seen on the computer, this will be what I will have printed in the OR. This is the implant, how it presents itself. We have the mapping of where this we have the holes to put the screws, so we can also plan more or less the length of the screw. This is a kind of guide for the osteotomist, but it's really guiding you more or less. We cannot rely on this guide. And then we see the procedure. In this case, we need to be a little bit more generous with the flap. So there was the placement of the pterygoid implant. On both sides, there will be the placement of the pterygoid implant. And then also on the second side placement, you see the drilling posteriorly and palatally to place our implant in the correct position. And then we do our skeletization, we go a little bit upper. In this case, we need, of course, to expose the palate, so we need to remove the incisor papilla, but we know it's not a problem. And then we can start doing our osteotomies from where we will have our abutment. The fitting of the implant is already in place, and we start putting the screws, starting from the big anchorage, so starting from the zygoma in this case. So we are screwing up the zygoma, our screw. And the moment of the truth is once we have stabilized the implant, we are taking the bridge and do the first drying. And we see that we already almost have a good occlusion. So we can finish to put the screws. Also was added a spinal implant, so in the spina nasalis for the anchorage in the front and the suture. So what we had on the model, we have in the mouth of the patient. Exactly the same. Immediately after the surgery, she goes home not with a denture, but with a bridge. We had the two pterygoid implants because luckily the fact that wisdom was buckling position, so we could avoid it during the procedure. And that's the happy patient after many years. She's like that, she's still smoking cigarettes, so I think she's fine. And now she changed. And finally, we have a smile patient. She always says that we change their life, but really, this is the soft tissue. After 1.5 years of use, or 2 years, we have a good seal, we have a good attached gingiva, so we are very happy. The patient is cleaning very well. And now, I want to go a little bit harder, because we know when we start to play, we want to go harder, yes? And that's the patient that comes in, but I think you already know this patient. Look how desperate she is in the lower arch, keeping a denture. She has an ulcer. She's a young woman. She's a successful woman, and she has the problem because she has the dentures moving right and left. And so, that's the X-ray. That's the X-ray that we have seen at the beginning today. So what is the treatment plan now? Anybody? So the idea for this patient was to do an overdenture in the lower arch and maybe a fixed solution in the upper. So we started, in this case we put in the articulator, we made the radiological template, and for the upper arch, I decided to make a subperiosteal implant. As you see, once again, we have the prosthetically guided treatment. We see where the anchorage will be. We see very nicely on the canine buttress, on the zygomatic buttress. So we can also use the pterygoid buttress by utilizing the pterygoid implant. And the patient accepts the treatment. And the same thing you've seen before. Here we have our implant in place in the mouth of the patient. Suture, so we see the abutments coming out, and the 4 implants in the lower arch and the pterygoid implant. This was the idea that she had at the beginning to do an overdenture, but she was desperate about the lower more than the upper. So she said, listen, can we do something more about the lower? Because now that I have a fixed upper denture, I'm not so happy with the lower. Okay, let me take a look what we can do for you. You see the soft tissue, and during this visit, the channel, she says that she wants to do the lower. Of course, then we can do the lower. We have no limits. We can do custom made. We are making custom made implants, and you could see from the X-ray before she had the nerve on the crest. So even when we open the flap, we have to open the flap from the lingual side, not to cut the nerve. If you cut on the crest, you're cutting the nerve. So we showed this to her. She's very happy, and we go back to the operating room. When she comes out, she has 2 more implants, but you see here is completely, we only have the nerve in this area, and we could avoid it. We didn't have to do any lateralization. We didn't have to take bone from the hip, from the head, nothing. We see after healing the multi-unit abutments in the lower arch. I just used the front implant with the healing screw to add the support for the temporaries, and was locked on the subperiosteal implant. And then the final treatment, we see the multi-unit. In the front they will also put the multi-unit, was made a mesobar, and on top we put the bridge. And that's how she changed our patient. Look at the profile. We have the profile that we have seen at the beginning of the lecture today. She changed, she has now to the front, she has the real soft tissue and the profile, the good profile of the face. And I think it's a good result. Also for her, will change her life, in my opinion. And that's her final smile. So in the meantime, when I was operating this one, I also had this other patient. She comes in, she has the residual lower teeth, it's not a good panoramic X-ray, and she also wants to be treated for the upper arch. We take her next, the pictures, we see that she has a Kelly syndrome due to the fact that she has this lower teeth, so we have a resorption in the front maxilla and a position in the posterior. And also I proposed a subperiosteal implant. She accepted the treatment immediately, and it was possible to look at the resorption in the front, where she has the nose. There's not much that we can do. She liked the idea, so also for her, we went to the operating room, we placed the subperiosteal implant, we fixed the temporary abutments inside the bridge during the procedure, and difference from the other one, she has the pterygoid implants on the second side. 10. So, also in this case, we planned our subperiosteal for the lower arch, because she wanted to do a fixed solution in the lower. We see we avoided completely the emergence of the nerve. In the front, extracted the teeth and placed 3 endoosseous implants. And that's how she looks like after the second procedure. Then we do the prosthetic part. Our patients, they like only one color, bleach too, so that we make them happy. And she goes from this, she goes to this, in a predictable way, in a fast way, with a good result. Just to finish the lecture, I wanted to show you a little bit more of the procedure. So this is the elevation of the flap. we are getting up here to the masseter attachment. We detach it for the placement of the implant. This was the case where we needed to extract the whole implant. We do the skeletization. Here she has a perforation of the sinus wall because in the past she had a sinus leaf before. You can see very nicely the emergence of the palatine artery. You will see in a second. You see here the emergence. Here, the emergence of the artery. Yes, how is going down. We are doing the shaping of the hard tissue. Palatal, luckily, everywhere we need to do it. Here we see very nicely. And the placement of the implant. So, last case, and I will leave you. This is a patient that came in. We wanted to rehabilitate the prosthodont, we wanted to rehabilitate the upper arch. He took an impression, he made the denture, he wanted to make work in, first of all, in an analogical way. So we see, he decided by himself to do the extraction and do the temporary denture. So that's what I got in after 5 months. So with this denture, we did the Evomine, did the surgery, looked at the defect of the bone after 5 months. So something that is very difficult to regenerate. Look at this. And we were able to put the bridge. Afterwards, when I asked him, what about the lower arch? Why this patient, what are you going to do? I need to put some implants for you. He said, no, we are going to do a skeletal denture. Why skeletal denture? Because he has an impacted tooth. And here you can place as many implants as you want on the left side instead. No, he said, don't worry, I will take care of this. Just talk to the patient. So I placed the implants where it was very simple. And on the part where we had the atrophy, we could place the subperiosteal implant without touching the impacted tooth. So we see after the procedure, he has the upper, lower, and the implant placed. And that's how it looks like when you take the final X-ray, the upper and lower. You see how it looks like on the skeleton, on the bone of the patient. I would like to tell you that this was successful only once, but I have many cases. I had to select a few of them to show you today, but it's a very successful treatment. It's something that it needs, of course, a learning curve. It's unique to our patient, and it works for the maxilla and it works for the mandible. So it works for each anatomical part of our patients. So with this one, I would like to thank you very much for your patience, for being so many numbers here today.